Welcome to Global Impact, the podcast that connects the dots so you don't have to. I'm your co-host, Michael Bosicue, speaking to you from the Harvard Club in New York City. And
I'm Melissa Ricci, speaking to you from sunny, well, not quite sunny right now, raining Los Angeles. Yes, it's raining.
that's really good because you guys have been having a heat wave. I was there recently, saw a lot of dry reservoirs.
It's been
Brown
hot.
grass, a lot.
Yeah, it's been very hot. But I cannot complain about the weather, considering I was in London for 12 years. All right. Well, look, you are in New York. What are you doing in New York?
Well, it's my first time back here since March of 2020. And I got to tell you, Melissa, it's a kind of eerie feeling to be back, because when I left here, Broadway, which is just down the block from me in Times Square, was literally going dark. And no one knew what was going on then. I was still doing interviews from my hotel room because studios were already closing down. Things were happening really, really quickly in terms of the pandemic shutdown happening. So I was roaming around, watching what's going on in New York City. And one of the things I really kind of noticed was how the inequalities were really going to be magnified, were really hitting. For example, a lot of people immediately started working from home. They weren't using public transit anymore. They were hardly going out. Those who could move to the suburbs or to the countryside. But the folks that were really disproportionately affected were those at the lower rung of the economic ladder, who couldn't work from home, who couldn't call in sick, who had to take public transit or even walk to work. So, who don't have proper internet, if at all, at home.
Yeah.
So it was playing itself out really quickly.
Right. And so there's something I wanted to mention too, because you're doing a tour right now, and you had your book. Your book. I know, I got it. I finally got it. So, Digital Pandemic, how tech went from bad to good. Has it?
You are not the first one, my friend, to bring that up. It's a bit of a controversial thing because, as you know, just recently, excuse me, in the press, a lot of press about how the rich got filthy rich and the poor got terribly poor.
Yeah.
And especially in big tech, the Jeff Bezoses of the world, their income, and the book points all of this out, just skyrocketed because the gig economy really benefited. Having said that, technology, which deservedly got very criticized pre-pandemic for things like stealing our data without telling us, for selling our information, for creating apps which they knew kept us very addicted.
So, Michael, would you like telling us why? Why did you write this book?
I had nothing better to do. A lot of people have asked me that. And previous to this book, I was working on a project called Digital Crack. And it was a book meant to be on smartphone and social media addiction. And of course, it's a very topical topic. It's going on all over the world. So I kind of was in writing mode. I was on a writing sabbatical in Portugal and working on that. And then, of course, COVID hit. Things started moving very quickly. So I kind of shifted into this topic of COVID, but keeping the topic of technology there, because I knew that tech would play a big role in this historic, unprecedented pandemic in two ways. Number one, keeping us connected, but secondly, accelerating by at least 10 years some of the trends on technology which were already there. For example, the tool we're using right now, Zoom, not well known, right? February, March of 2020, but now everyone knows that word. It's kind of become one of our not favorite words, but very popularized. So I thought that it would accelerate, for example, because of the lockdowns, distance learning, gig economy, especially shopping from home. The huge one is telehealth, especially in places like China, exactly, where people were actually in China were afraid to go to the hospital, and in Russia, by the way, too, because they viewed them as places they could get sick or even die. So they preferred. So now China, I put this in the book, has developed a really cool ecosystem where you can get your consultation online, where you can order prescriptions online. You don't even have to leave your house. And then on top of that, you get reimbursed by the insurance, and it gets audited by an automated bot. So it's all kind of a sealed ecosystem. It's fascinating.
It's actually cheaper too, because I'm using telehealth, and it's a lot cheaper because they don't have to pay for locations and everything. So they can actually cut down on this, and people can afford more private care or whatever, you know.
And then the other thing I found in all of this process, COVID was a kind of existential event for the middleman, right? You know, cutting the middleman out, bringing prices down. And it's amazing, Melissa, even in the process of writing this book, technology enabled this book. I self-published it on purpose. I wanted to see what it was like. And I did not want a publisher telling me what to do, and also telling me, well, if you're going to write a book, it's going to come out in 2 years. This thing needed to come out right away. And so what happened, it was fascinating. People actually found me online, an editor in New Zealand that I didn't even know was following me. And he said, I love your stuff and I want to be your book editor. Let's do this. He found for me a graphic artist who produced that beautiful cover. And then also—
I'm gonna show it again.
Yeah, that's a beautiful cover, which is a play on that COVID kind of icon that we've all become so familiar with, and it's kind of been integrated into a circuit board. And then even our wonderful editorial assistant, Pretty, who's become a mentee of mine, an intern, we connected as well through technology. So that's why I kind of labeled the trailer of the book written locally and produced globally. Oh yeah, and one more thing. The trailer was produced by a chap in Los Angeles who I introduced to as well. I had a interior book designer in Victoria, British Columbia. Never met him, but also introduced. So maybe one day I need to throw a party for all these people and celebrate this.
It's going to be like global party. Right. We can have a Zoom party now.
Sure.
Hey, people do this, you know, Zoom parties. So we can all stay in our countries and, you know, and still have a drink. Okay, so let's just start with a bio before our guest jumps in.
And one more thing to end your answer to your question, Melissa. Everyone wants to find anything else about the book. About the book, digitalpandemicbook.com.
Yes, yes, that's important. And also you can get it on Amazon, right? I got mine on Amazon, and you can get the digital form or the hard copy. Yes. I like reading copies.
And then I'll be voicing my own audiobook in the next 2 weeks. So that will be sent up to the heavens as well. And people will prefer to consume the book through audio. It'll be ready for you in 2 to 3 weeks.
Yeah. Right. And I just started. I can't say I read the whole book because I just got it recently, but I started it and get it. There's no filter. I mean, it's the best. Seriously, if you want to go through someone's journey through the pandemic, and you know, I mean, there's so much in it. I'm not going to spoil anything. It's worth a read, definitely.
Thank you very much.
Well, yeah. I mean, I'm just I'm like I think a third of I read a third. So yeah, I have to stop sometimes. I have to sleep, but. So I can look fresh for the show and you know, everything else, but it's very captivating. It's very difficult to, you know, to stop. So I think people they're gonna enjoy all your stories and everything. All right, so let's just go and introduce our guest now. So a little bio about her, as we usually do on the show. So we have with us today one of the top infectious disease experts in the United States, Dr. NAHID Bhadelia. She's the founding director of the Boston University Center for Emerging Infectious Diseases Policy and Research. She's a board-certified infectious diseases physician and an internationally recognized leader in highly communicable and emerging infectious diseases with clinical, field, academic, and policy experience in pandemic preparedness. Michael, would you like to keep going?
Sure. And in addition to this, Dr. Bhadelia is also the Associate Director of the National Emerging Infectious Disease Laboratories, a state-of-the-art maximum containment research facility at Boston University. She has served as a subject matter expert to the U.S. Center for Disease Control and Prevention, Department of Defense, the very well-known and respected global fund to fight AIDS, tuberculosis, malaria, the World Bank, and COVID-19. And of course, Dr. Bhadelia has, especially during COVID, become a very familiar and authoritative face on such programs as PBS, the NewsHour, keeping people informed and up to date on what's going on. So,
hello, Dr. NAHID Bhadelia, and welcome to Global Impact. So thank you so much for taking the time, by the way, to joining us today. We know you're busy and you're doing a lot of important things right now, researching and saving people's lives, hopefully, and making the world better. So I have a question. I just learned that you have, I think it's a new organization. Can you tell us about your new organization, what it is about, how you started it, et cetera, et cetera?
Thanks so much, Melissa. Michael, thanks for having me. So I am the founding director of Boston University's Center for Emerging Infectious Diseases Policy and Research. And a huge part of what the center does is stuff that I've been doing my whole career, which is working on building resilience against emerging infectious diseases threats. So CED, which is what we call it, Center for Emerging Infectious Diseases Policy and Research, does that through, we do transdisciplinary research, looking at everything such as disinformation, misinformation during outbreaks, to how do novel diagnostics, get put out during outbreaks, and how do they work, and how can they be equitable. To doing a lot of work on actual strengthening. We work with partners. I've worked both in Uganda and Liberia, many of other faculty have worked elsewhere, to look to see how we can build resilience through healthcare systems and within our communities, and really trying to promote equity in the way that communities experience pandemic, and build resilience from that perspective. And then the last thing we do, and a big part of our concentration, is engagement, is making sure that we're not leaving the public out of the fight against emerging infectious diseases. And we do that through education and training, as well as outreach to legislative affairs folks around the world.
Right, amazing. And when did you start this organization? When was
We launched June 1st of this year. We've been doing work in the underground for a while, and as I said, a lot of the projects that are under CED now have been around for almost a decade. But yes, the center itself launched June 1. Come see us at www.bu.edu/CEID.
We will put everything in the bio anyway, but I was about to ask you. You anticipated. That's good. Michael?
And, you're certainly, Dr. NAHID, one of the voices that not only speaks about pandemics, but warned of another one. And it strikes me, and this indeed is one of the things I put in my book, is that there were a lot of voices unequivocally stating that the world needs to be prepared for another pandemic. And yet a lot of those warnings, it seems to me, and a lot of others, were not heeded. A lot of governments, even big corporations, were caught unprepared. Why is that, do you think?
Well, right after the, as you know, Michael, one of the things that I was involved with, or have been over the years, is actually Ebola virus disease outbreaks. And the big one that I was involved with is in 2013, 2016, West African Ebola virus disease epidemic. And in the aftermath of that, a lot of us did the same reflection. And there was a report that was put out by the National Academy of Medicine that basically said that we tend to cycle between panic and neglect. And every time there's a pandemic, there's a ton of actual capital and political capital that, gets invested. And then when the pandemic recedes or outbreak recedes, the funding goes away. The number one reason we're not prepared is that we tend to provide funding when we're threatened. And then as nobody's paying attention and the political cycle changes, funding for preparedness programs, surveillance programs, a lot of those things drain away. And this time around, what I'm hoping is, with the impact that COVID has had, how it's touched every corner of the world, one of the commitments that we make, both nationally and internationally, is that commitment is sustained and allows us to build that resilience in the long term.
And one of the things that surprised, I think, a lot of people, perhaps even yourself, was that a lot of medical systems and hospitals were caught unprepared, even in the United States, where we are now, the richest nation on earth, not enough PPE, ventilators, things like that. Is that a problem to do with flawed supply chains? Is it a problem with money? Because just quickly, I remember Dr. Mike O'Ryan at WHO pointing out to us that Actually, university hospitals in the United States are relatively wealthy. The budget of the WHO is smaller than many university hospitals. So how could something like that happen?
Yeah, good point. And Michael, when this happens in resource limited settings, we completely understand, right? I mean, the fact that there are parts of the world where people can't even get primary care, and so how do you and can't handle endemic infectious diseases? How do you manage this? So there are a couple of reasons where, let's take US as an example. I can't speak to NHS in the UK and elsewhere. One of the basic things that I see from US perspective is that our healthcare is a private sector and our public health is in the public sector. And one of the big things has been how to prepare all these different entities that exist disparately in the private sector to create area where surge capacity could be created, right? Leave empty beds so that you could, or invest in empty beds so that you could create that surge capacity, or put money into training healthcare workers continuously. And ASPR, the Assistant Secretary of Preparedness and Response in CDC, did do that after the Ebola virus disease epidemic. They gave funding to hospitals to create both specialized units in some cases, but also to train their healthcare workers. But that funding was actually just about to end when this happened. But the other reason why is because that funding and that kind of work, it wasn't enough for the kind of threat that COVID posed. That was faced against that money was aimed at like taking care of 1 or 2 Ebola patients, not hundreds of COVID patients that come through the emergency room. So part of the way that I think we failed is that we were not prepared to handle those big surges for all the reasons I talked about. And the other is with emerging infectious diseases, science lags behind. And I think that it was miraculous that we got safe and effective vaccines as quickly as we did. But I think that part of what was overwhelming to everybody is that the fire was not just in one area. Other outbreaks that I've been part of, you bring in resources from elsewhere when the health system's overwhelmed. And as you just mentioned at the very beginning, supply chains everywhere were overwhelmed and doubly overwhelmed in resource limited settings. And so we did not have a system in which regionalized hubs could exist to have those kind of personal protective equipment. We did not have a system to say that essential medications are needed everywhere. How do we make sure we can ramp up production when it's needed so that the whole world gets access to them? And I hope we do after this pandemic.
Yeah, and I think I speak for everyone when we salute the work you've been doing and many, many others on the front lines and putting your lives at risk during the pandemic. One more question for myself for this round, and I'm sure it's something on the mind of everybody, is where are we in your mind right now with this pandemic? Is it done with us yet?
Yeah, I think we're somewhere in the middle. I know people don't want to hear that. I think we're well off. Now it becomes where you live, as it does with most infectious diseases. I think that the trend so far seems to be the vaccines that most of the high income countries have been able to distribute seem to be holding up. Even the Delta variant, which seems to be the most dangerous so far in terms of its transmissibility, in terms of potentially increasing severity of disease. New data showing that our current vaccines, the efficacy may be reduced a little bit if you just got 1 dose, but they still seem to be protecting. As long as you're fully vaccinated, they seem to be protecting against hospitalizations and deaths. So from that perspective, if you live in a community that's highly vaccinated, things look pretty good, unless we're thrown a wrench. And the wrench that we could be thrown is that as this virus continues to transmit elsewhere in the world, it continues to evolve. And, could we have the bad luck that a variant comes along that reduces the efficacy of vaccines even more? So that's one part. The challenge in high income countries is that there are pockets of undervaccinated and unvaccinated states. So many states in the US, Louisiana, Missouri, a lot of places that have like 30% fully vaccinated, I think it's still low and they might face that threat. The reason I say we're still halfway through is because most of the rest of the world is not vaccinated. And what you're seeing as a trend is that, many of the countries that we thought may have escaped the worst because they maybe had younger populations, maybe there wasn't as much introduction of the virus because the travel had stopped globally, more or less. You're now seeing, what happened in India, the fact that you had the evolution of these variants, multiple gatherings, and a variant that's more transmissible and affects younger populations completely overwhelm the healthcare system. And that's playing out currently in Uganda. I work in Uganda, and I heard over the last 2 weeks, my colleagues are telling me 9 doctors passed away in Uganda, and that's a small country with many fewer doctors than even my state of Massachusetts. And you're seeing that played out in Latin America. You're seeing it played out in West Africa as well. A lot of places are now seeing cases go up, and until we can vaccinate the rest of the world, we're not done, because those variants could come back and affect us as well.
Mm-hmm. Can you please explain what is herd immunity, and are we achieving that target? I mean, is that the only way we can actually achieve, get around this through herd immunity, or it's not?
Yeah, so I'll talk a little bit about what herd immunity is, and I'll tell you why I don't like that term. So
Okay.
herd immunity is the concept, and it generally is applied to vaccination, is that you get enough people vaccinated in a community so that the virus can't continue its transmission, because the people, even if you're not vaccinated, there are enough people vaccinated around you so that you are protected because of that buffer. And so the disease can't continue to propagate, right? And the term that I like is population-based immunity or community immunity, because in some places we may achieve that, like, well-vaccinated states in New York City, New York or Massachusetts, my own Massachusetts, New Hampshire, you may have places that are highly vaccinated that don't see a lot of transmission because of that. But in terms of a global herd immunity, I think a lot of people that you'll talk to will say that it's unlikely that we'll be able to achieve it, and if we do, it may not be for years, because of the amount of virus that's out there, and the lack of sort of enough vaccinations and the measures to sort of stop it, and that's why it might take longer than we expect.
Okay.
And I clearly you're someone who keeps your eye on the globe and what's going on in public health. So Singapore and Taiwan, New Zealand are standouts here who have done, at least in my opinion, a lot of things the right way. Early, sharp and short measures, contact tracing, that sort of thing. But I'm really surprised. We're seeing now an outbreak in Taiwan, which is doing very well. Victoria State in Australia has gone into another lockdown. And I heard from actually an editor of mine in New Zealand that there are fears there that they might be headed into some dark clouds as well. What is happening in those particular countries where they seem to have been doing everything right, yet the virus seems to find some way, some crack to exploit and get back in there?
Yeah, I think it's the testament of the fact that we're all connected, and lockdowns, public health measures, all of those non-pharmaceutical interventions have always been a stopgap until we get vaccines. And I think that what you're seeing, right, in many of these countries is now that there are more transmissible variants for the same reasons that we're seeing this in resource-limited settings, right? More travel, more transmissible variants. You're sort of seeing potential reintroduction of the virus that is raging elsewhere in the world. And so I think the way for many of these countries to sort of come out of this cycle of having to lock down is the same thing, is access to vaccines is the way that we stop this in the long term. But I do agree with you. I mean, I think that they have had some advantages. I will never take away the hard work that those countries have done, right? Immense amount of investment in testing, contact tracing. That's what we needed to do. The advantage in their favor, there are two advantages. One is that they're smaller, Australia less so, but definitely Taiwan and Singapore. It's much hard to herd the cats in a big country like United States. The other advantage is they had prior experience. My own experience in Ebola virus disease showed that countries that have had prior experience with a pathogen or an outbreak have institutional memory. They have public memory of what it takes, to do those non-pharmaceutical measures and things like that. And having had that from the initial SARS in Pacific Rim, in the Pacific Rim, I think really informed many of the public health policies in that area. And so one can hope that our experience here in United States and UK and elsewhere will do that if we are faced with the next one.
Okay. And you mentioned the United States before, and I've been here 3 weeks and I've been observing what's going on. And it seems that, if I can use the word, we're reaching a plateau here in terms of vaccination, that those who basically wanted to get vaccinated or were convinced to do it have done so. But frankly speaking, I've been talking to a lot of well-educated, well-traveled people who are saying, well, I'm going to wait and see what happens. And I mean, I went into a vaccination center the other day in California at CVS, talked to the pharmacist there. They said we used to have, for example, 300 or 400 people a day, and now we're having a handful. Does that worry you, is that there's going to be that large segment of the population that is going to take a wait and see attitude?
Absolutely. And I think there's two words to this. I think that if you're in a really well vaccinated state, if everybody else around you started to get vaccinated, the advantages of that are that you're less likely to come across somebody who has the infection, right? So, but if there's enough people around you, even in that well vaccinated state that did not get the vaccine, then now you've taken away the advantages of that creating that buffer that comes from high rates of vaccination. And so the concern would be when there are communities, even in well vaccinated states, that where vaccine hesitancy groups together, and that's where there's a concern, whether it's vaccine hesitancy or structural barriers to be able to get the vaccines, which I think the Biden administration now has been investing a lot of money over the last few months in terms of bridging that last mile, taking away structural barriers such as not being able to take time off work, answering and transportation issues, being able to get to vaccination sites and coming back, making sure there's a vaccination center within 5 miles of everybody in the United States. Those are good steps. The other part is harder, which is states where you're just seeing lower vaccination rates overall, the ones that I mentioned before. And some aspects of this are difficult because, as others have, I think this has been mentioned in the news many times, as the Kaiser Family Fund and others have talked about this, whereas that some of the vaccine hesitancy there is actually politically, it seems to fall, across the political spectrum, where people who are more conservative leaning are less likely to get vaccinated. And I think it's an aftermath of just the political division that's going on in this country, regardless, in the background, that's now is manifesting itself in the vaccination campaigns. But I mean, I said this, it's not just, I think, disinformation, misinformation, and political division. I think that many of the states in the United States that you're seeing having these low vaccination rates are actually also the states that traditionally have the lowest per capita investment in public health. Between 20 and 30, like there's a difference in terms of states that might spend at $20 or $30 per person for public health versus somewhere like Massachusetts that spends over 100, right? And so these traditional, not as much investment in public health, local public health infrastructure may be playing a role that we don't yet know, and that could be something that we could work on as well. I'm worried about those states because the Delta variant may take a foothold. We've only seen 10% so far of the current. Currently, Delta variant only makes up about 10% of the strain here. UK's experience was they saw a doubling to the point where now over 90% of the cases they're seeing is due to Delta. And we've always followed the UK in terms of patterns, which means that if we see the numbers of Delta variant continue to go up, those states will see surges, and those surges may get even worse during the cold season, during fall and winter seasons, where this virus may may find it easier to get transmission going.
Okay, so what would you say to the people who are afraid of the vaccine? What would be your take? What would you say to them? Because there's a lot of people who right now are very worried about this vaccine. I mean, it's pretty new. Some people, there were a lot of also articles and about people having issues with it. A lot of people don't want to be guinea pigs, and a lot of people are waiting to see what happens. So what are the risks of waiting at this point?
Yeah. Well, Melissa, I think there's the hesitancy that I've heard, right, in my own office when I see patients is multifold. One is that sometimes they're kind of just concerned about how would we get to a vaccine so fast. And I want to set people's mind at ease. The science behind the target of where to target this virus is we've had 20 years of experience from the initial SARS, right? The mRNA technology has been around for 30 years, and the last few years has allowed us, the last decade has really allowed us to stabilize it. It was simply that the things aligned well for us. It wasn't really the science that was undercut. That's usually what takes time. In most vaccines, it's finding the targets, and we lucked out. The second part that takes time is finding funding and taking the risk away from companies of being able to take those products that they find promising into trials, and then the trials themselves. So in this case, the first and the second, first we lucked out, second, the Operation Warp Speed invested all that money that allowed us to bring that time down. The third, there were no shortcuts. We went through a phase 3 trial. These are vaccines that millions of people, billions at this point, and many, depending on what you're talking about, over 2 billion people have received vaccines, multiple different vaccines, mRNA vaccines, the traditional, vector vaccines such as AstraZeneca and others around the world. And when you give that many vaccines, with most vaccines, with most medications, you may see rare side effects. And that's what we saw. And the fact that we picked up the signal in the haystack shows that our systems work. because what the vaccines are doing are multiple. They're protecting you against severe disease. They're keeping you from getting any infection at all. That keeps you from potentially going on to have side effects such as, or long-term effects such as long COVID, which I'm starting to see in many of my patients. They're also keeping you from transmitting the disease to others around you, which is making your entire community safe. So even if you think you may not be at risk, you getting vaccinated is creating that buffer so your community can go back to normalcy. And so I would urge people, I think what I've seen is that there are a lot of myths and a lot of disinformation and misinformation about this. Please seek out good information from CDC, from WHO. Just anytime you see disinformation, try to go back and look at another source that's reliable before you take that as the proof of authenticity.
Yeah, and indeed, yesterday the Financial Times had a big investigative piece about the disinformation. A lot of it is Russian-backed and coming here, and the way they put it is Russian-backed trolls, but also organizations set up here are quote-unquote super spreading disinformation here in the United States. That led me to my question. I've worked with WHO and UNICEF in places like Nigeria and Pakistan, where you can find quite severe pockets of hesitancy, but what they would do there is really rely on influencers like faith leaders, like celebrities. Here in the United States, do you feel public health officials have really utilized all of those levers as well to encourage people to get vaccinated?
We're starting to see that, and some of so for many of the minoritized communities, many of the communities of color, we've seen traditional sort of hesitancy, and you've seen now you're seeing the Biden administration as of two weeks ago even talk about many of the networks of faith-based organizations and innovative campaigns like the neighborhood barbershop being involved in getting the information out. And I think those are important. There are pockets still that I think we need to work on. One is immigrant populations and limited English proficiency populations. I think we could do a better job in doing outreach there. I think the hardest part is this political divide and disinformation along political divide, because I think the only thing that I could think of, and this has happened, there are political leaders on the right, including many political leaders on the right that are physicians, who could have taken the opportunity to be champions. You've seen them sort of almost put out information that could lead to more vaccine hesitancy rather than help. And that's the trusted type of trusted. If we can't get that from the high up, I think the other thing we got to look at is faith-based organizations and more community organizations in conservative communities to help answer those questions. The best way in many of the situations for me has been face-to-face with your physician, with your caretaker. I think we've been able to answer questions that people may have, that and really go through information that they're getting fed and just go through it step by step and sort of show that where that information doesn't make sense.
Okay. Let's travel, right?
Yeah, I was about to jump on this about the passports, the vaccine passport. I mean, do we risk segregating the people, the have-nots from the the vaccinated people, and how is that going to work? Because America, you're not supposed to force anybody to do anything, and it's very scary because at this point we're all responsible of our own health, and I don't think it would be fair, to not let people who don't feel yet they want to be vaccinated to not travel. So how is that going to work, do you think?
So one thing I should point out is that we've always, in many countries, many parts of the world, there's always been requirements for vaccine travel, for vaccine sort of proof of vaccine for travel. So yellow fever is a perfect example of that. I've had to carry my CDC card for yellow fever. And I'm sure, Michael, you have as well. If you've been to Nigeria, I'm sure they've asked you for that in the past. So there's always been, there's many countries have already required that. So it's not a new concept to COVID.
Right.
I would say the concern here is, I think the federal government here in the US has already said they're not going to step in to do that. Some states have worked on trying to make it easier to say they would create certifications if private businesses require it, then people can have access to that. I think that this is a tough spot for businesses, which is where it ends up being, because cruise ships is a perfect example, right? If you're not sure the vaccination status of people who are on a cruise, the demographic of people who are on the cruise are older. There may be people with medical comorbidities. We've seen how norovirus outbreaks just break loose on ships, on cruises. Imagine an airborne or aerosolized virus, and if there are enough people who are not vaccinated, it could really lead to outbreaks. And so it is a public health concern beyond just the individual's choice. And the person who's not vaccinated, I think I would be scared if I was not vaccinated to go on a cruise, because if I didn't know who else in my close proximity might have COVID, and we know 50% of the transmissions occur from people who are asymptomatic at the time, or haven't yet developed their symptoms. And so that would be of concern to me. And it would be of concern to me if I was vaccinated and was immunocompromised, so that the vaccines, are not as efficacious at the same level in people who may have autoimmune diseases. I'm sorry, not autoimmune diseases, immunocompromising diseases. And so that would be the other concern for me. I think that the answer is much clearer when it comes to healthcare. And I do think that hospitals should require healthcare workers to get vaccinated, because healthcare workers, we take an oath of saying first do no harm. And we spend a lot of time around people who are immunocompromised and people who, families who trust their loved ones to us. And, if we can transmit that disease without realizing, we're putting their lives at risk. Hospitals in general, whether it's COVID or other outbreaks that have been part of healthcare systems, if we don't foolproof and create that infection control, have a chance of potentially serving to propagate that infection. And so I think requiring it in hospitals makes sense to me. I think that the other reason is because we've always done that. Many hospitals require flu vaccines. We require the MMR vaccine. There's other vaccines that are already required in those settings for that same reason.
Okay.
And something before we get to our kind of rapid fire questions to get to know you a little bit better. I was on the WHO press conference probably about 3 weeks ago now, and something the Director General said pretty much shocked me. He said that on the topic of mental health, the number of people coming out of this pandemic in terms of the impact of trauma, mental health trauma, will be greater than after the Second World War. Does that worry you as a health professional as well, that that's going to be big and perhaps not enough resources or attention is being devoted to that?
Absolutely. Before I answer that, Michael, I do want to point out one other thing from Melissa's point. Yes, I definitely worry about vaccine passports and inequity, but from not the perspective you think. I think of it from resource-limited countries and high-income countries, because if most of the world is not getting access to vaccine for years, does that mean my collaborators in resource-limited countries can't travel for conferences? You know what I mean? I think that that's where I think the equity issue really comes in, is people who don't even have access to vaccines. How is that going to play out? So sorry, going back to your question, Michael, yes, because look at my own, whether it's the outbreaks that I was involved with in Uganda across the border from Democratic Republic of Congo, or whether it was the one that I was truly involved with long period of time with the West African Ebola epidemic, virus disease epidemic in Sierra Leone, the devastation at the community level, but also in particular among healthcare workers, was immense. And the reason I believe the number that the WHO officials just talked about is that, as opposed to the world wars, almost all of us felt the personal pain of loss. The pandemic hasn't left any of us untouched. And if it wasn't because we lost somebody who was loved, we may have lost our jobs, we may have lost our homes, we may have lost our friends. And for healthcare workers in particular, on the front line everywhere in the world, this will be trauma that we carry for a really long time. And it's trauma that we share across our profession, that may impact whether or not they show up, the healthcare workers around the world show up for the next pandemic. So yes, we definitely need to invest on that.
Okay, so if everyone's in agreement, we're going to move on to these rapid fire questions. And this is something we love to do to help our listeners and viewers get to know our guests a little bit better. So Melissa, if you want to kick it off.
All right, so now we can relax. I love that part. So Nahid, any iconic, inspirational people you look up to?
Ooh, so many, but one that I will just mention because I interacted with her only a couple of weeks ago was Joya Mukherjee, who spoke at our event last week on global health equity or global vaccine equity. And she said the one thing that struck me, which is that charity is not a way out of a global pandemic. And Partners in Health does a lot of work around the world and helping sort of build health infrastructure and health equity. And so I am a big fan of Joya, Dr. Mukherjee, because she reminds me the North Star to moral compass of how we get out of these problems.
Wow. Okay. Michael?
Actually, I was going to give the next one to you, but this is one we both thought up together. Stilettos or flats?
I'm sorry. Well, we had to ask.
Yeah. Kitten heels.
So important. Like so important.
It's totally important. I have retired all my heels, but I will do kitten heels. That's about as high as I will go these days. And I am very short for people who've met me in person. So yeah, I don't take that advantage.
Well,
my
I
back
lost
is
because
Michael on your feet.
I thought you would do stilettos still. Michael was like, no, she's a flat person. We were debating about it in LA when he was in LA. That was funny. Right. So I lost.
That doesn't, doesn't keep me from being a fashionista, by the way. You should see my closet. However, the heels are gone because, I am a runner. I can't mess with those heels.
Yeah.
Well, I get it. All right, next. Your favorite medical TV show or movie, if you have any.
I'm always the one who's like yelling at the screen, going, "You cannot shock people without a pulse. That's just a false." So I'm the wrong person to ask.
I can imagine you like going crazy, like you can't do that.
Yeah, but I mean, I don't watch a lot of serialized TV anymore. I watch a lot of Netflix and stuff. But back in the day, I watched a fair amount of ER, so I suppose that could count.
Okay,
and perhaps anything on your summer reading list, aside, of course, from digital pandemic. But
it is absolutely on my reading list. Yes.
Anything you got on your reading list? Yeah.
So I just, so small thing about me, I love sci-fi. I like sci-fi books as well. And so I just finished Project Hail Mary by Andy Weir. So he wrote The Martian. There was a movie made out of that. And a great thing about Andy Weir's writing is that there's a lot of science embedded into his work. And the Project Hail Mary is about the race in time to save humanity, which, it seems like I tend to bring my day job into my reading.
I was gonna say, sounds like there's a connection here.
Yeah, so it's a great one. Yep.
Yeah. Okay. Nice. I'll have to check it out.
And you've traveled to some pretty challenging places in the world. Where do you like to go take time off or vacation?
Well, I found so many beautiful places attached to places that people traditionally think that, they would not vacation at. Some of my favorite places in the world, I would do, so there's north part of Uganda has a Murchison Falls National Park. Absolutely gorgeous. Uganda is one of the most greenest places on the face of the earth I've ever encountered. The biodiversity, the incredible sort of like, you feel like this could be the cradle of life, and so Uganda is incredible. I've had incredible travel. I've hiked through Patagonia and Torres del Paine. And so that's an excellent, if you have the opportunity, definitely would do Patagonia. It's incredible. And then Iceland, because it feels like you're on the surface of Mars. It's incredible. Topography, geography, the Northern Lights. Yeah, that's amazing.
Northern Lights. It's magical.
Yeah, it's amazing what you can find in countries off the beaten path. I mean, I found beautiful places in Papua New Guinea last year. It was amazing, while on mission there. So, okay, and then turning on to questions from our audience. So, thank you for everyone who did send in questions. And this one is from Susie in Orange County. How do the virus and vaccine affect people with autoimmune disorders?
Yeah, great question, Susie. So what we know is that people with autoimmune disorders, as you may know, as many of them also tend to be on immunocompromising medications. So they're on medications to suppress their immune system. And so in general, patients who have a depressed immune system tend to have a more severe course with COVID. And that's what we've seen in majority patients who are immunocompromised tend to do worse. They are more likely to get hospitalized, more likely to pass away from the infection and have a tougher course. And so that's the tough part. What we know is that vaccines protect you from that. And so if you're vaccinated, if you're somebody who has autoimmune disease, or if you're somebody who has immunocompromising disease, definitely get vaccinated. There is concern that, even with vaccinations, as I mentioned earlier, that the rates of, like, if you're immunocompromised, you want to both get vaccinated, but you also want to stay away from places where there might be a lot of people who may have an infection, because the efficacy of the vaccine does go down a tiny bit, depending on the condition and things that we're talking about. But I think your question may be going to something else, which is that what people have found is that, in people who've, and our own research has actually started to show this as well, that if you've had COVID, as we've seen with other viral diseases, you can develop autoimmune antibodies that are attacking parts of your own body. And so my research group has actually been working on that. We found that 7 months out, there are people who are COVID survivors who had autoimmune antibodies against parts of their own body. We don't know what the importance of that is. There's a money investment by NIH to try to figure out long COVID, and we're trying to tease apart if that's playing a role. Interestingly, though, that if you get a vaccine, for people who've had long COVID, if you get a vaccine, anecdotally, you take this, with a grain of salt, anecdotally, it seems that their symptoms get better. So if you have long COVID, and there might be a component of autoimmune disease to that, actually, it seems to be, people's symptoms seem to get better after vaccination.
Oh, okay. Okay, so we have a question from Enrico from San Francisco, and that's a long one, so I'm going to have to read that one. Why do you think that a large percentage of the US population have little trust in NGOs, such as the CDC or the WHO, in their handling of the COVID-19 virus and the pandemic? Is it a messaging issue, something more substantive, or a mixture of both? Can it be fixed, and how?
Yeah, very good question. Very good. So, and honestly, if we can answer some of those things, if you can answer some of those things, you might be helping a lot of people around the world. So I do have some hypotheses. So one is, what I found in my experience over the last decade or so dealing with emerging pathogens in particular, has been that when it comes to emerging infectious diseases, this is always a challenge in terms of messaging, because these are diseases that we learn about as we respond to them. The first 100 patients teach you about the disease, and they show you how to take care of patients, what medications work, and so always what I found, whether it's Ebola virus disease or, Lassa fever or something else, as you're learning about these diseases, public health policy seems to be made on shifting science, and the general public finds that disconcerting, because they say, well, last month you told me to do this, and now this month you're telling me to do that. And so there's that inherent difficulty, because the science is evolving, how to make public health policy in that setting. And so that unfortunately, part of that challenge is part of the challenge of emerging infectious diseases, is science shifts because we're learning about the disease, and public health policy shifts with that, and that can breed distrust. And we need to work on the best practices of how we communicate that. And I think we could have done a much better job of doing that. All CDC, WHO, others. The other part is that we don't invest that much in all those companies. I'm sorry, the NGOs that you talked about. I was going to say CDC is a governmental organization, not non-governmental organization, but the same story, right? Where we let's take WHO for an example. WHO's budget, only 20% of WHO's budget is assessed contributions. That means that those are required contributions from countries. 2/3 of the WHO's budget nowadays is just voluntary contributions. They're basically walking around with a charity bowl trying to make sure that they get enough money. And not only that, but a huge part of their budget is completely earmarked. So when an emergency hits, they have to go out and find more funding. They don't have, we haven't equipped WHO with the type of both support, as financial support, as well as more oversight to be able to, or contributions to be able to sort of make them the kind of body that we would want them to be in these scenarios. And so that's one, and same thing with CDC. CDC budget is sort of, improving now. It had sort of stalled when it came to, over the last decade, their funding in public response, public health emergency response has gone down, has been cut. And other programs has gone up again. But those types of cuts affect organizations' ability to be nimble, to go in a big way, as Mike Ryan would say, right? Go fast, go hard, go first, right? That's have no regrets when it comes to outbreaks. And if our organizations are not well equipped, they can't do a good enough job.
Right.
Great.
Wow.
Great.
That's good.
Doctor, if I could throw one in at the end that I think also came from an audience member many weeks ago, but it was for Dr. Boris Lushniak, the former acting U.S. Surgeon General. And it was a very interesting question because the listener was asking about the new normal, what will it look like? And Dr. Lushniak said, you know what, it probably won't go back to the good old days when we're shaking hands, and perhaps that was never a good hygiene practice anyway. But what do you see in the future in terms of how we're going to perhaps greet each other or interact with each other?
Yeah, there are some things that, and I think going back to that experience, I did a training for Taiwan CDC, I don't know, 2015 or something, and they were telling me that this is why I was learning about the Asia Pacific experience after SARS, and they were telling me the impact and the change in culture after SARS, in many of the countries that were affected. And there, so I was going to say that I hope everything doesn't go back to normal, because there were really like unhealthy things that we did. Like we went into work sick as a badge of honor. Like, what were we thinking? I hope that's a practice that goes away, because the billions of dollars every year go into drop in economic productivity when workers can't come to work because they got the flu from their coworker. And so hopefully that changes. Hopefully that hand hygiene and all the other stuff that we are now practicing is going to help reduce the impact of other diseases. And so all of those, I think that there's going to be hesitancy in for some people to go back to normalcy. For others, I think they're just rearing, and we saw that after 1918, people have talked about roaring 20s and how it was people just went out and partied because it was a way to escape the pandemic. There are tons of other things that happened after 1918. Crime went up, violence went up. There's a lot of potential badness that happens in the aftermath of large world-shaking events like this COVID pandemic was, and so I think that we, yes, there are things that may change, but I think things will continue to change that we need to keep our ears to the ground for.
Super. Yeah. Well, Doctor, we've taken up a lot of your time, and we're very, very grateful. And as said previously, on behalf of Melissa and myself, and I'm sure our viewers and listeners, we salute the work that you do and everyone on the front lines in this pandemic. We're so, so grateful to you. We've been speaking with someone who's very familiar to many television viewers already, one of the top infectious disease experts in the United States, Dr. NAHID Bhadelia. NAHID Bhadelia is the founding director of the Boston University Center for Emerging Infectious Disease Policy and Research. Thank you.
Thank you for having me.
Thank you. What a wonderful person she is. She's so lively. I love her energy. She's amazing. And I'm very grateful for all the information she gave us. And hopefully people would have more answers about, the COVID-19, the vaccine and everything. That was a very good one.
Indeed, indeed. And it was wonderful engaging with her and having her on the show. And we will not just focus on COVID on every episode of Global Impact. There are other things happening in the world as well. But I know that I'll be hitting the road a little bit more than before. So I'm hoping, and probably Melissa too. So between the two of us, I think we're going to be able to inform a lot of our discussions on the show about what we're actually seeing here on the ground. And just quickly, Melissa, I have to tell you that, I've been here a little over 24 hours. And again, it's the first time since March of last year. What a difference. New York is back. But I have to say, it's just shocking to go around and see the economic carnage.
Is it bad?
Landmark New York restaurants and bars, especially, that are closed down, boarded up, never to open again. Iconic places. Just quickly, I spent almost an hour yesterday at a Italian restaurant a few blocks away from here, 50 years old, run by one of the siblings of the founders. And she was telling me what a tough time it is right now, just keeping the restaurant, the doors open. Yes, people are coming back, but it's making up the losses from the past. And the changes of US city cores, a lot of people have moved out and away. So
yes, there's a migration in different states at the moment. Like
so
people are leaving California, New York,
Seattle. A lot of different dynamics at play here that we have not even begun to explore or address. So
what about masks? Because we had a mandate. So basically yesterday, I think it was yesterday, we didn't have to wear masks anymore if we were fully vaccinated in California? What's the situation?
Well,
in
here,
in New York?
actually, a lot of people indoors do when they go to a restaurant or a bar, they wear it coming in. And similar to California, then they take it off when they're actually eating. But I've seen a lot of people on the streets as well. Look, for anyone coming to a place like New York where it's starting to get busy and congested again, my recommendation as a savvy traveler, if you will, is to wear that mask, because even though you may be vaccinated, others may not. And I think the science is still out there on, I'm not contradicting what Dr. Bhadelia said, but you know, the research is still quite early. So even though you're fully vaccinated, it's not yet clear, I think, whether you could be a carrier of COVID. So there's a lot of still things playing out here, but I noticed yesterday going through Times Square, a lot of people there, very little social distancing. So it's not a big deal to wear a mask. Look, we're all used to it by now, and keep up the hygiene etiquette as well. Wash your hands as frequently as possible. The one last thing, the one challenging thing I found is in the aircraft. The airlines, I know they're in a rush to get back into business and get that revenue flowing again, but they're really packing those aircraft full. They're very congested. A lot of the routes are being served by narrow body aircraft, so there's even less opportunity for spacing people out. So one quick tip I have for people, anyone thinking of traveling is, well, 2 or 3 is number one. I tend to board last, so avoid the rush. I tend to grab a window seat. I tend to keep that air flowing as much as possible. And when it's time to deplane, wait for everyone else to leave and then grab your stuff and go. Those are just touch points that you can minimize as you're getting back into the air and traveling. So.
I mean, the air is recycled. Remember, we had that conversation with the previous guests that the air is actually pretty, you know, like it goes through a system of heat that just, you know, like.
Well, that may be the case, but I got to tell you, in Canada, we have excellent tracking of flights. And I can say as a few weeks ago, several domestic and international flights landing at Canadian airports every day with several confirmed cases of COVID. So, yeah. Unfortunately, we have a good contact tracing system that we can alert people 3 or 4 rows back and forth where that case was identified. So just while we're transitioning right now, is, you know, protect yourself and, you know, take all of those precautions. On that note, let's just put out one more message that we tend to do with every edition of episode of Global Impact, is that we're talking a lot about technology again on this show, and it's there, it's available. There's still many people on lockdown, but even if they're not on lockdown, a lot of people have either been furloughed, lost their jobs, or they're waiting to get back to work. Perhaps they've lost loved ones and they're alone. Reach out to them, even for a few seconds. It could make a very big difference in their life. So thank you for taking part of your day to spend with us. It's been a pleasure on behalf of myself and Melissa.
Thank you very much for joining the show and just supporting us. And yes, keep on logging in and tuning in, because we're going to have amazing guests in the future. We have a lineup and a lot of surprises. So stay tuned.
Bye-bye.
Bye.
Bye.